Okay,
can you do it? Yeah, can you do it? Yeah.
We are having a session on CTO with Gerald Werner. He doesn't need any introduction. He's from the clinical center in Darmstadt, Germany. My co-chair is Dr. Chiung-Jen. Apologize if my pronunciation isn't correct. And then we have panelists, Thomas Gerber, Dr. Kim, and Dr. Hamanaka, and Dr. Kalyanasundaram. We're ready to start the live case. I give the word to my chair, Dr. Wu.
Okay, Gerald, what about just started to introduce the case? Then we have a lot of expert here. We are going to enjoy the case.
Yes, thank you, Dr. Wu. Thank you, Jacques, Koolen. It's a pleasure to be asked to transmit a case during TCTAP, one of the biggest and most important meeting in Southeast Asia. And it's a great honor to contribute. I'm here with my colleague, Dr. Koch, and my team around me, Mrs. Bender, Mrs. Koslik, and Ina Felsch is outside the registration. Then I also have a member from Siemens here who helps me with the CT co-registration. We will demonstrate this also during this course. Now let me introduce the case. It is a 49-year-old male. He had this bypass surgery in 2016. He has also peripheral artery disease and several interventions. Next slide. He has a lot of risk factors, among them diabetes. He stopped smoking, and he has, after some time post-surgery, again developed chest pain and dyspnea. He has normal renal function, which is important, and he has a quite favorable body mass index, which is good for our X-ray balance. Next. Oh, the EKG is upside down. I did it. Now turn your head to the left, please. And you see that he has a small Q wave, but this could be also due to S1, Q3 axis, so not a relevant scar. Next slide. He had a thallium SPACT with extensive defect in the inferior wall and on echo a normal LV function. Then they did a diagnostic angio in February this year, and I will briefly show you the results. He had a venous graft to the right and a lima to a PL branch. Actually, the LED was not severely diseased, so you can discuss, of course, whether this was a surgical case. Next slide. This shows you the right coronary with severe disease, then a big RV branch, and then after the RV branch, there is an occlusion. You also see calcium. And what you see on the image in the RAO projection on the right side is the distal graft sequence, which is still patent, but the graft itself, so it was a connection between the PL branch and the PD branch of the right, and this is still retained contrast from the diagnostic angio there. So the right is occluded right at the side branch, which makes it a bit more difficult. We calculated JCTO score 3 and Castle score 4, so it has no stump. It's calcified, it's longer than 30 millimeters, 20 millimeters, and for the Castle score, post-cabbage is an extra criterion. Next slide. This is the left system. We don't have too much information. What's important is that it seems to be the occlusion distal cap located directly at the crux, which makes it a little bit challenging. There are septal collaterals, several septal collaterals, mostly in the distal LAD. Next slide. Next slide. So this is still shots of the venous graft osteal occlusion, and this is the lima to a very tiny PL branch. Next slide. So what we do here, of course, is bilateral approach, radial to the left, femoral to the right, preferably short guides. I took a longer guide for the radial because it's a tall person. Please stay with the PowerPoint. We had done CT before the procedure, and we use IVUS, of course, for planning and for optimizing during the procedure. We have just corrected the ACT. It was down to 174. I added another 5,000 of heparin to get it above 350. Next slide. So we want to demonstrate CT for planning and guidance. I start, even if this looks to be a retrograde case because of the crux cordis involvement, we will start with an antigrade wire. Then we want to secure the retrograde approach and use low radiation settings throughout. So especially low pulse rates, 6 pulse rates, and Cine as little as possible. And the Cine is especially with low power in our setting. Thank you, and let's discuss this case. Maybe with the introduction of the setup shot that I did today. Let's show, first we did the co-registration. Oh, stop. Let's first show the CT. Switch from IVUS to CT. Oh no, you can see the CT, yes.
Right.
So this is the CT of the right, and we did kind of a parsing of the occluded segment. Yeah. So here we did follow the contrast filling, and when the contrast filling left us, we were looking at the Hounsfield units and kind of step by step extended the possible course of the vessel. You can see it, I think, there. Can you show me the volume rendered presentation? Yeah, So here you see the blue one is the RV branch. And then we have one longer block of calcium, which is in the middle of the segment. So the proximal cap has no calcium and the distal cap has little calcium. And now we go back to the angio. We did setup shots to do the co-registration. So now it's kind of synchronized with our system. And these are the setup shots. You need to have 2 angulations, and then you can kind of overlay this whole thing. And now we want to come to the CT setup, the angio setup. Let's show both planes, please, A and B. Yeah. So this is the simultaneous shot that we did. I have an AL1 in the right coronary, and I have an EBU 375 7 French in the left with a wire down the LED to stabilize this position. So now I give it over to you for discussion.
Yeah. Just before you start, Gerald, a more general question. In the light of the EuroCTO study, ischemia, etc. My question is, what's the functional class and how much does that guide you in performing a procedure? And I saw you made a MIBI spec to have an idea about the amount of ischemia, I suppose. Is a MIBI
yes,
spec
it's a large defect.
Is it a routine for you to do MIBI spec before to start a CTO procedure?
No, when I would look at this EKG and I would look at the echo, I wouldn't do a spec, but he was a referral patient.
That was my question.
Yeah. So he has regular wall motion there. So the ischemic burden with a rather large right is evident.
Yeah.
And he has symptoms.
That's my question actually, because there's a normal LV function. Why do you still need the MIBI? But it was, yeah, okay.
If I may, I was going to ask whether you thought the circumflex bifurcation stenosis actually contributed to the area of ischemia that you're seeing on the SPECT as well in the native vessel.
Yeah, but the circumflex is actually small. The distal branch is grafted. What we will do, and the main supply is from the LAD. Yeah, the main collateral supply. You see the PDA filling early on. So I don't think that in any way the occluded right is adding to the ischemic burden of the donor vessel side. I wouldn't look at the
I agree entirely, Gerald. I think the right is the culprit. It's just in the spirit of trying to give a young man complete revascularization for long-term prognosis. It does look like that lesion isn't too complex to do.
We will do it after the CTO in one session here.
Okay.
Yeah.
Dr. Werner? Yeah, so where does the main collaterals come from?
The main collaterals come from the LAD. I will stop the image. Wait here. They are unfortunately very distal. I show you here.
Yeah.
Now we can see them.
Yeah, this is one of the major collaterals here. There might be surfable collaterals, invisible collaterals here, and there is one collateral from the first septal,
Yeah, right.
but this here, this usually comes very close to the crux, which is not so ideal. So there might be connections here and here, but this is not ideal because we want to have a long access to the crux. So in the interest of time, may I show you the IVUS that we first did of the RCA?
For the proximal.
Yeah.
Okay.
So we did a dilation because you see the right coronary is highly stenotic. And so we did an IVUS here. Let me see.
So you just pull back from the RV branch after balloon dilatation.
Yes.
Okay.
But I must say that obviously. Here it comes. Yeah. Okay. So here we have the RV branch. You see the IVUS?
Yes, we can see it.
So now we pull back on at 3 o'clock. We see the RCA.
Okay. Yeah.
Yeah. So it's rather soft here.
And
this is the proximal
as well.
And this is the proximal RCA concentric calcification, something for shockwave or whatever. Yeah. But very diffuse disease. The vessel size.
So still dilatable by what size of balloons? Gerald?
I started with a 3.0.
3.0. Okay, great.
A sapphire.
It looks surprisingly soft to me. I angiographically would have expected more calcification on the IVUS.
The calcification.
He's a young guy, so maybe the plaque isn't as calcified as you think.
Yeah, but the calcification comes down distal, in the middle segment.
Okay.
And actually on the CT, it looked even full moon. I'm not sure whether this is representative. Maybe the CT was not accurate enough. So our approach is to try to puncture the proximal cap, to stay in the lumen, go down with the wire as far as possible, and then try to connect from retrograde. I don't think we will be able to enter the distal cap from antegrade, but go down as long as possible. That would be my start now.
So, okay, Gerald, I'm very much impressed by all these modern techniques, but can you explain to us what makes you to start IVUS or to use CT scanning? What's your indication, and in what percentages of your cases you're using those techniques?
Well, CT scan is used in about 5 to 10% in our country, but I know, or in my lab, I know it's much more frequent in Korea. They are experts in this field, and Japan, because of cost restrictions. CT information is always helpful, especially in long CTOs. And here in this patient, it helped us understand that the calcium is predictably in the mid-segment of the CTO, not in the beginning and not at the end, which is important for getting into the distal cap. The second, IVUS is used almost every day in CTOs, especially in these side branch situations, where you are feeling much better if you are really confirming that you are in the true lumen. So we went with a run-through extra floppy into the RV branch. Then we dilated, as I said, and we did the IVUS. And now I have brought a fine cross microcatheter, which is my favorite antegrade microcatheter still, because it's very small. It works with 7 French together with the IVUS, with the Volcano IVUS here. And I try to, but it's very narrow because of the calcium, so still very difficult to work. So this is the IVUS live image. So the IVUS, we need to bring down again.
So this is a real-time IVUS guided
image.
Okay.
Yeah. So I tried with an XT first, but the XT was just buckling because of the calcium around, not in the cap, but because of the resistance in the vessel. So I went with a Gaia second.
Okay.
And let's see. You see the wire there?
Yeah.
Here is the wire. Very difficult to see, actually.
Imaging says that at the center of the 3 o'clock.
You see, now let's go to the A-plane fluoro, because you see, I could probably have So you see the A plane here.
Yeah, right.
We are already on course in the vessel.
Yeah.
I can overlay now. I can do an overlay here. Yeah, that is kind of what you see on the A plane. Yeah. It's not working with the, it's not moving with the heart, but it's kind of an orientation. And
that looks good. I mean,
and if you show me the CT scan, please show the CT. Yeah, then you see I also have the B plane. I have a biplane system, and as soon as I move here, yeah, the CT moves with this whole setup.
Okay.
So I know that I'm on the right course here. So I try to follow with the fine cross. The fine cross nicely follows. Yeah. And now I will remove the IVUS because otherwise it's getting too bulky there.
Yeah, right.
And the IVUS is not needed anymore. So so it's very important.
A comment. I think I don't use fine cross very much, particularly in calcified vessels. I'd probably go with the turnpike or something a bit more tapered, and just because I'd be worried that you could, if you got the guy through the occlusion, the microcatheter may not follow.
But yeah, you will be surprised. The fine cross almost always follows. Because you cannot work with a turnpike in the 7 French IVUS setup. You need to have 8 French then. So now we are at the area where there might be the calcium. So I'm
lot
probing.
Of resistance.
No resistance here, which is not good.
So I wonder, can you see?
Are you still going ahead with the Gaia right now, Dr.
No,
Werner?
I'm just working with a Gaia without the fine cross. The fine cross is back there inside the cap, and actually it was moving quite good. Now let's see. Let's do the overlay. Would look like it's okay.
Well, can you
Did you
see
see the overlay?
calcium on the angiogram?
Yeah, I probably need to make a shot here to see it because we're maybe
like
around the
tracking it.
calcium.
Looks like you're tracking it.
It's very likely that we go subintimal there, but I will now make the contralateral shot
Okay.
and see how it looks. I think we are on course. We're still far away, 10, 15 millimeters. It looks like on course. If I get closer, and I don't have the ambition to enter, but at least I can mark. Yeah, there is some resistance now. So I will try to get the fine cross a little bit further down.
So as you're working, Dr. Werner, I mean, first of all, very challenging case.
You see the fine cross easily goes down. Yeah? You underestimate the fine cross, the good old fine cross. I can tell you. But this is too much movement, so I'm probably subintimal here.
Yeah, there's a lot of movement.
Okay.
The tip is moving too much.
Because from the original, it seems CT, they have a, as a full movement calcium.
Yeah.
So
we probably go around this calcium. So I will stay there, and now we will try the contralateral access.
Yes.
Yeah.
Yeah,
So
nice point
I
here,
actually.
that you switch in an early stage to the.
Arun, one of the question regarding the ADR, is this a good time you switch to a ADR directory, or you want to just go retrograde as a Gerald proposed?
So Sion.
I mean, this is a very interesting case, and one of the questions I did have for Dr. Werner is, with the CT, I mean, we were concerned that the distal cap is really a bifurcation. Do you have a landing zone? I mean, I guess that's kind of the real question. If you
No, you don't have.
You don't. Well, then I would do exactly.
I will show you. I did some shots here. Here, this is a shot on the landing zone. I think you are the master. You might find a landing zone, but not for me. I don't find a landing zone there. I have a small notch, which is helpful if I get inside from retrograde, I think.
Yeah. Yep. I mean, I think it's going to be a difficult reentry case. I would probably do exactly what Dr. Werner is doing, which is, I mean, you have usable collaterals that are not super high risk. So from an efficiency standpoint, I mean, I think he has now purchased anti-grade. I would definitely try to, you know, retrograde would be my second option. If that fails, try and do a high-end ADR.
So actually,
but I mean, the retrograde really, I think we're committed to this just because of the landing zone and also the entry through the crux, and then to connect out will just look. I think it will be better, and the flow, the Timmy flow, will probably be better coming from the other side now.
Yep.
There's a long dissection there. So even if we need an ADR, you know, the distal flow, and then how are you going to negotiate that bifurcation? I think coming from the other side is a low risk. He's you know, he hasn't got much of a pericardium, so you can't be too worried. Although we mustn't be complacent about post bypass, but we, you know, he wouldn't. I hope wouldn't get any complication. And there's some nice septals to surf as Gerald.
So let's go to the septals. This is the setup in REO shallow. To see the exit, the entrance into the septals. As I showed you, the best connection is the distal one. But I first went into the second septal and did a injection. There might be some surfable connections, but for if I fail distal, but I think there might be some faint connections. You don't see them, but that's something for surfing. And then I went into this distal branch.
Gerald, this is 150 Caravel?
This is a 150 Caravel. That's my favorite septal catheter, actually. It serves me almost always.
Do you use a fine cross 150 at all for your septals, or is it pretty much Caravel?
No, Caravel. Because it's also the option then for going epicardial. And I have here available the XS, the Corsair XS, as an option. So I have brought this already a little bit preparation, and now we try to kind of navigate with a Sion, because I think that branches are too small for the suo. But yeah, the suo is also a good option, I think, but in septals, when you need more push, it sometimes fails you. Yeah, but this is not finding the right way here.
It seems from the 2016 Japanese expert CTO registry, Japanese experts, they were switching from Sion more to the Suo 03. So maybe I can ask Ichiro. Ichiro's
So that's right. So almost 70% of the retrograde channel wiring is using the Suo 03. Now they're very popular.
You're using more Suo 03 instead of Sion. Why?
Sion or XDR. Because of the safety issue.
Safety. Even the septal.
Even the septal, yes.
Okay, great.
Yeah, I fully agree. Even here, Suo is the top seller, but in septals sometimes it's, but you never. It's not a waste of. You cannot damage the septal, but here I cannot get ahead, so I try to do another injection. Yeah, and try the Suo. It's more risky to damage the collateral with the Sion than with the Suo. But sometimes the Suo, especially in septals, I have the feeling that it might not be pushing when the muscles contract. It's certainly for epicardials is number one, and certainly more than 50–60% of our collaterals are done with the Suo.
Your tip injection seems only a CC0, CC1 connection. So maybe if Suo 03 cannot go, maybe XTI is another option as Ichiro just suggested.
Yes, I think so. So that if there's a tip injection, shows some route, so it is possible. Yeah, because but without any sign of the route by the tip injections, I think it's very difficult using the Suo 03 or even XTR. Some doctors are using the XTR for the septal softening, but I don't think that works always. Yeah.
So I was just kind of curious, like you guys have talked about Xeon, Suo03, and XTR, but there's no talk about Xeon Black. I mean, for surfing, I did use Xeon Blacks a lot if I'm going to surf. Do you guys? I mean, what's your take? Do you guys use it much, or in the different?
I have to say, I hate that wire. It causes so much trouble, I think.
Alles gut bei Ihnen?
We've got such. It's a good one. Okay, I may be being a bit harsh.
Tut was weh oder
I
so?
agree with the discussion. The Zero-3 is just.
Ja, ich bin am Arbeiten.
You can. You just have to use more than one, because if you let it run too far, it bends and it buckles. But that's fine. Just get another one. It finds your channel and it doesn't cause any mischief. I like that. And the Xeon Black for me, I always seem to get a little bit of a blush. Sometimes I get worried about that. High ACTs, you know.
Obviously, here I have trouble. Is collateral, as sometimes happens, that it looks better on the setup shot than if you go close. So it doesn't work. The Xeon Black, I agree with Arun, is also my favorite for if I would have to go to the other septal, I would use a Xeon Black. Because it's really not so dangerous if you are careful, if you're not sticking it down, but you let slide it down.
So Gerald, usually how long you would spend with the same septal, then you try next one?
Until I destroy it.
So how about
how
about using the vein graft as a retrograde approach?
Yeah.
Because,
I'm not. Yes, it's an option, but I don't like it.
You don't like it?
The thrombus load.
Yes,
that's the danger of using that.
So actually, I don't get ahead here, and I'm not sure why.
So this is still the Xeon or
Suo?
Oh, Suo 03.
Oh, Suo.
Okay. Why not
I already
XTR?
No, XTR. I'm not familiar too much with the XTR, and maybe there are 2-3 cases in my memory. It's really too tiny.
Yes.
So let's switch to something else. We need to do an ACT here.
I just wondered whether with the tip injection, you may be a bit too distal. I just wonder whether, if I have a look back at the tip injection, actually it's a bit more proximal than the distal part to the caravel.
Maybe you'll find some branching, connecting.
I think it's a bit earlier.
This channel is very small, so I wonder if the tip injection can.
I can. Actually, it's stuck very. It doesn't get out actually.
The wire?
No, the
microcassette.
Yeah, it's very surprising. Das war die rechte. I did a foolish thing. I just removed my right coronary access. Okay. Should be able to get back there.
Okay. We have a channel.
That sometimes happens.
That's what happens in the middle of the battle.
Middle of the transmission.
Yeah.
It's okay. You can blame us for distracting you.
Yeah.
On the other hand, I have to say, Gerald, it was a good point you made there when switching directly to the retrograde approach when you got stuck with the antegrade. So that was, I think, a good educational moment. Now you have to repeat it. So.
Yeah, but I think it seems to work here.
Yeah.
Most of the time, once you've been there, it'll get down easy.
It looks a little bit different.
Yeah.
Definitely, I'm in another RV branch. Yeah.
There's another curve there.
more like this.
Oh, yeah.
Maybe now I'm
better. Looks a bit
better.
better. Yeah, it's.
I'm more in the center of the calcium now.
Looks like it, yeah.
So you're still using the Gaia 2?
Yes, it's the same Gaia. Probably it's now in the block of calcium.
What does the CT say?
Let's show the CT and the A plane. Yeah, yeah, looks like. And the A plane. No. The regular CT. My co-registration image. Yes, exactly. Yeah. So this is a segment of calcification. Now we go to B plane.
That doesn't look too bad.
I mean, why not just wire escalate here now? Looking at that, take a Gaia 3rd, because you're going to need a bit more push.
Yeah, but I don't need because I make progress, as you see.
Oh yeah, I've just seen now. Yeah. Yeah.
Yeah, but I'm not sure where it does go. Let's see.
Right, but it doesn't move that freely as it used to do.
It's a little bit maybe better, and it's also more difficult, but I can advance the fine cross.
I mean, if you haven't got much contrast usage, what about doing a contralateral now?
Yeah.
Yes, I will do. I will do.
That's a good idea.
And your creatine's normal.
I just had to add some heparin. We were again down to 204, despite having given 5,000. Just no contrast is fortunately not a big issue here. So.
Do you have a warning system for that? For X-ray and...
Yeah, we have a... I see he has a GFR of 130, and X-ray contrast uses about 100 ZC.
Okay.
Actually, we're very close.
Yep.
Yeah, on the front, on the A plane, you see that we are probably below. But it looks definitely a little bit better than before, actually.
Yeah.
And we know that here it's actually very soft. So you see, I get a different course with my branch, with my Gaia. No. Yeah, we are.
Yeah, it's way off.
We're a little bit off. So as I have not given up on the retrograde option, that is better than before. And if we prevent my colleague, he has to hit my arms when I ever touch this wire again.
It's always the colleague's fault.
No, it is not.
I know the feeling. Or the fellow. You have to blame the fellow, even if they're not in the hospital.
So, yeah, I will make an injection again here. A und B, bitte.
And Gerald, would you consider surfing on the other septals at this point if
Yes.
you're not making progress? Yeah?
Yes, I will definitely. There are some other options here, maybe. Maybe I take one of the other branches. A little bit around. I'll switch back to the Sion because the Suo didn't help me here.
You know, I have to say, I did like that big first septal you pointed out right at the beginning. Okay, it was quite a tight angulation with the stenosis at the beginning, but I think once that's negotiated, it looked like that was quite straightforward.
Yeah, obviously, I will switch to the first one again. Yeah. While I again push my wire, it's unbelievable. But fortunately, the fine cross is stuck so tight that I couldn't take it out again. There is the tendency today for me to work on this antigrade thing. So let's get the whisper back. So, yeah, the retrograde approach is easy when you are retrograde, and then it's not so easy when you want to make the connection. Sometimes the septal passage is easier than you think. And here, actually, I calculated that this septal approach should be not too difficult. A little bit miscalculation.
You never can tell.
Yeah, I mean, it's always one of those things with retrogrades. There's one step which is like, I mean, you get this done and then you're going to struggle with reverse card. There's always something, right? You never know.
So the only problem here is our time limit of 1 hour. I would not be in any concern here that I'm not able to get retrograde with 4 septals which I can use. Actually, so.
And one of the things
I was there.
demonstrated was the utility of CT and the overlay in terms of when you're wiring it anti-grade. We didn't have to keep injecting retrograde. I mean, you could kind of show with the CT and calcium on angiogram that you were in a safe zone, which led you to advance your fine cross. I think for those of us that don't have CT overlay, this is a pretty cool, really useful technique. It's not just a toy.
Yeah, I agree as well. I think it's been a beautiful demonstration. I just sort of wonder whether the caravels, I'll be interested to see if it's going to give you enough support with the guide. I don't know whether I'd probably go with a Corsair or...
Yeah, but you will be surprised. This is pre-shaped.
That looks a bit more promising to me.
Yeah.
You will be, I wouldn't use the caravel if, we do 150 retrograde CTOs each year. 90+% with the caravel. I wouldn't use it if it would break frequently, and I wouldn't use it if it doesn't follow. So, but I know rightly people are a little bit concerned because in the initial introduction of the caravel, people used it like the Corsair. And a lot of tips were destroyed. And if you just don't use it as a Corsair, but rather as a fine cross traditionally, pushing, it works nicely. So I have switched to Xeon Black.
Is my favorite wire.
Okay, that looks good.
That looks good.
Yeah.
Move down a little bit.
Well done.
Yeah, let's see.
Now if the caravel doesn't go, you know,
no, that's good.
That'll be controversial. The other thing I find with the caravel, I don't know whether other people do, because it conforms nicely, particularly in tortuous vessels, even with short guides, you run out of space. And that can be really frustrating sometimes.
Now, let's see whether I'm really there. It's a little bit funny behaving. You should be, it's not there.
It's not there, no.
It's not there. No, definitely not. So this was, yeah, that's something that happens when you think it runs smoothly. Again, it runs smoothly.
Oh boy.
So again, there must be a branch.
This is a branch between the PT and Hero branch in between. So if you can go somewhat, this is go to the Hero branch.
You are in a vessel. You are in a vessel.
Yeah.
Yeah, it's gone down.
Hero branch. Yeah, right
there.
And
makes things a little bit difficult. This is this intermediate branch that's there sometimes.
Yeah, right.
So now let's see how the caravel behaves. I just push it.
I'm using the same caravel as Gerald just proposed. Retrograde nowadays.
You're going to continue with the same wire now, Gerald, or you're going to switch to a...
Yeah, now is the problem that I'm not where I wanted to be. Now this looks like I'm at the crux.
You're at the crux, that's the point.
Hero 1 is a question because your caravel is easy to go retrograde into a Hero branch. And this is from the beginning, it seems like the PD and Hero just branch tip as you propose. Sometimes this kind of case, double lumen microcaster would be a good option to keep it stable here and here. Another wire can
could be.
Yeah.
Could be.
Good point.
I will try now with a soft wire with an XT. We need a new XT because the old one to puncture the cap. Another option that I still have, the PDA is of course the most important branch here, that I could also leave this as a marker, because now the access point towards the crux is not as wished. It's not straight. And actually it's not the PL branch, it's a third branch there.
Could you just tip injection from the this microcatheter to see the caravel?
Yeah.
Yeah, we can do activity by
I
print.
can try if I have a flow back.
Okay.
You should, I mean, yeah, I mean, you're in the vessel. That should really delineate the distal cap pretty well.
I hope everybody realizes how interesting and helpful biplane is, especially for the right coronary.
Yeah,
beide planes, beide Ebenen. So I could aspirate here blood. So I inject. Ah.
Yeah, some
Got a landing zone
upstream,
too. That's great.
into the distal RCA.
So actually the branch, my wire already went right.
Yeah.
Yep.
So, but the XT should be good here, I think.
And what is your plan
Does
B,
your CT?
Gerald, if the XT
What do you
doesn't
mean?
work?
Regarding CT?
Well, you've had such beautiful CT imaging, and there's a Siemens person there. Did the CT of the distal right show that sort of trifurcation type? I mean, does the CT help again for us?
Yeah. No, the trifurcation is not visible because this is such a small vessel. We saw nicely the bifurcation, the crux, but the trifurcation was not. I
guess
didn't
you could
see
just
this
see
branch.
it there. Now we know there's another branch. So.
Yeah, this is the way.
You're in a great spot, Dr. Werner. This is great. Okay.
This is the way of the vessel.
Yep.
Let's see whether I can get a little bit less diaphragm.
So if the caravel can follow that XTA, that would be great. Then we can do a connection in the CTO segment.
That is a challenge because, of course, this is the tip of the wire. No, it doesn't. So I lost the position here. Now I'm here again. There is a little knuckle. Arun is happy.
Knuckle.
Yeah, but that's not good. Probably.
Dr. Werner, if you're having trouble with a caravel advancing, is now a good time for you to leave the wire there, exchange it out for a Corsair or something with a little bit more oomph or beef, like so that you could kind of, because you got to get into the CTO segment.
No, but yeah, but I don't think that the caravel or any other microcatheter will go now. But what I do is use this as a marker.
To come integrate.
Just an integrated approach, huh?
Let's see. I have redirected my wire. You saw.
Yeah.
Let's check the other plane. How it looks here.
Looks good.
Doesn't look too bad. I don't want to.
Do you feel much resistance there?
Yeah.
So as the next step, so you're thinking about the reverse cut technique.
Yeah, first I need to get the wire a little bit further up. My retrograde wire. And I'm thinking about switching the wire. Or I leave it here and do dilatation.
Yes.
Yeah, probably that is the better way. The problem is that the field XT probably will go back, move back a little bit.
But if the XT is inside preg and the antegrade gas second is a subintimal, then reverse cut does not work at this position.
Yeah, let's see. We need to prepare antegrade anyway. So what we do now is change out the fine cross, bring down a balloon. I'm just thinking ahead a little bit. I'm just flushing it out here.
I mean, if you can put the wire more distal, then if you take a balloon down on the wire you have and see if you can do an anchor and then see if you can suck the caravel round, that's one option.
Yes, yes. I want to dilate
the
now.
Distal wire further along, I think.
Gib mir mal ein 1-0 Rio. So we will start dilating. I was also thinking of introducing a guide liner or guide extension already, because with such a long diffuse disease, a guide extension makes things much easier. But the question is whether I introduce it right now or later.
You're using a very small balloon, I understood, Gerald?
Yeah.
Yeah. So
Rio Ray, Tazun, the Terumo Rio Ray 10 is one of my favorites.
10 by 5? 10 by 5? Is that smallest?
10.
10 by 5.
No, it's, 1 by 5, exactly.
Okay.
So let's see. The fine cross went down easily, so the Rio Ray should have not too much of a problem.
Yeah, it's tracking pretty well.
Start dilating. Same 12.
Also, this balloon can tolerate high pressure. Sometimes when up to
you see the retrograde wire. That's the problem when it's only a short advancement. Already was moving back down.
So Gerald, just one quick question: why don't you exchange your retrograde wire instead of an XT to something more steerable, like you've got, which is also
the medium one?
Yeah, you have a retrograde wire from Mark, so
Arun, I agree, but actually I have only 2 arms. And one, I do. So we need. This would be ideal if the one operator works antigrade and one retrograde. I think I heard this concept in Scandinavia. They do it sometimes.
Really? Okay.
Yeah, but I'm not so sure whether it really works. But it would be good here. But first, I prepare what I have to do anyway. Yeah,
absolutely,
I have to do it anyway. So let's get a 2.0 Rio Ray. And then actually my wire here for the retrograde would be an ultimate, because it's more steerable and has more power to get the caravel forward. Yeah?
Totally powerful wire, yes.
I would love to have the Miracle Neo 3, which is available in Japan. It's a fantastic wire. Unfortunately, not exported to EU. I'm not sure whether it's available in Taiwan.
Not yet, not yet.
It's there for 4 years. Yeah, I had occasional samples. I don't understand why is Asahi holding back this wire.
Yeah. It's Japanese company style. They want to keep the best product in Japan.
I will tell the Asahi company man.
Company's policy.
Yep. Let's see what happens.
So, okay, let's get the ultimate.
Maybe we can check with the SJ Park to see if we can extend the transmission.
Yeah.
I think it would
be
they can cut nice final result. You know, I think it's a big vessel.
Yeah. So I have dilated with a Rio Ray 2.0, and now we come with an ultimate. And I have still the reference image there. I need to go a little bit more cranial for that.
So curious if you can use that Ultimate 3 as some advancement into the CTO segment, as you just already dilated. Maybe you can, for the education, we do an imaging guide to see where the position of your retrograde wire.
Yes, I will. I will definitely, even if we cannot finish here, I will show it in the wrap up.
Okay.
Yeah. So here's the ultimate. Going into the
DL.
Yeah, okay.
That's nice.
Some more advancements, if you can.
Yeah, but it's not good enough yet.
A dual lumen catheter would be useful here as well.
Yeah, but I'm not sure whether I will be able to through a surfing. Now you see the caravel advances.
Nice, very nice.
Now I would even feel confident to go to a Gaia 3.
Yeah.
But you see, I can. We have not yet dilated this segment, yeah. But
very close.
You see,
close.
we make progress here.
Yeah,
great.
Great progress.
Almost overlapping.
Yeah, it is overlapping. We can dilate here.
Across the balloon here.
Yeah, perfect.
Dilate. Yeah, 10, 12. We show the A plane, the other plane.
Beautiful.
From aerial, it seems quite close of antigrade.
Yeah. So we are definitely in the same space. So this is just a matter of patience and progress.
Yeah.
We missed the audience for the applause.
Yeah, you have the zoom button.
Okay.
There's a zoom option for applause.
Okay.
Is that right? Okay.
So we are proximal. Yeah.
So Gerald, why not upsizing of your reverse cast size? I think the vessel size is 3.0 at least. You can just.
Yeah. I will. Yeah, but this is what we do now is the modified reverse card.
Okay.
Down with a small lumen, not to create too much of dissection. But you see, I go in the A plane because there is still too much distance there.
Would you consider bringing your guide extension catheter now? I mean, you're kind of in there beyond the Audi branch, yeah?
Yes. But let me just advance like this.
Just keep going.
Nicely done.
Take it all the way up and.
Beautiful.
Very free.
Wow, time.
So that's very important to go to the frontal plane here when you deviate, and you see also in the B plane that we are actually overlapping. And maybe we save now some money.
Yes, sir. Sweet, perfect. Strong work.
The old guys still do it.
Okay, great.
Okay. Wir sind durchgekommen, Herr Pioch. Yeah?
Nice.
So now we pull back the wire, and what's very important to get the antigrade wire back so you don't inadvertently create too much subintimal space now. Yeah, so now we dilate 10, 12. There could be still the problem that I will not be able to follow with the caravel. But it's not there. You see, I just push it. Caravel is almost in the guide. Release. We advance the wire. Remove the balloon a little bit further back and caravel. Trap. And now the caravel is in the guide. You see it?
Yeah.
For your information, we are 35 minutes fluoro time, and we have an added milligray of 517. 527 milligray. Yeah.
Fantastic.
That's and the image quality was good enough for you, I think.
Yeah, right.
Yeah. Great demonstration
release.
so far, Gerald.
Beautiful.
So here a little trick. I trap my caravel with 2 atmospheres, so it doesn't go back.
Then
G3.
and also can stop breathing when you externalization of R3.
Yes.
Great.
Beautiful.
So I think now we have done the major thing really in 1 hour. It did look like with the sepals in between, but maybe we can wrap up.
Yeah.
And I will continue, and then we show the final images with Ivis.
Don't forget to tape them.
So the final will be externalization, and you dilate, and you do a before dilate, or you want to do a double lumen microcatheter to get the wire down into the PL branch to preserve major 2 branch before your dilatation. This is very. Sometimes you dilate that the IMH can be extended into the bifurcation. So what is your proposal?
Yes, that is. I will do Ivis. And according to the Ivis image, I will decide whether I definitely will try to get a wire into the PL. And then decide based on Ivis and plaque distribution whether we do a 2-stent strategy or a 1-stent strategy. So now the wire should come here.
So the Lima is on the PL, is that right? Gerald?
Jetzt Ballon 10. Yes, the Lima is on the PL of the circ. It's a tiny branch.
Okay, sorry.
Yeah. It's a very tiny branch. So we will do dilatation with the 2O. No, first I have to remove the caravelle. So hold this one. This is also an important maneuver. When you remove the caravelle, again, be careful. It's not a corsair. Don't twist it. And you saw it's a calcified lesion, but I'm not promoting the caravelle. If you are happy with a Turnpike LP, if you are happy with a Corsair XS, use it. I just show you that it's a very safe instrument if you are careful. I broke only one tip of caravelle among the probably 600-700 I used. So now we have removed the caravelle to protect the collateral. And now we do a 2O balloon dilatation, and then we do IVUS. If you stay with us with IVUS, probably would be. So now we do IVUS. Actually, the problem here is we are in a very tiny side branch. So I actually cannot stand across the crux in this position.
Yes.
So what I will do most probably is, according to the IVUS, put a stent, put all the stents proximal to the crux, based on the RG3, and then go down and wire the PL and the PDA and do the final stent before removing the RG3. Yeah, that's an important step here, because we are in a side branch which we don't want to put the stent towards this side branch. Wir brauchen IVUS jetzt.
That's an excellent point that Dr. Werner just mentioned. I mean, the other approach is to take a new dual lumen catheter, go down and wire the PL. But I think this is a more, how to say this, a more cost-effective way where you don't have to take another.
Was ist? Ja, das kommt von. Also, gib mal MO 5 Milligramm. Das kann jetzt von diesen. Ja, ich schau mal, was wir da ändern können. The patient has a little bit of complaint, chest pain, so we need to check. The ACT was, I will just inject into the left system, so we are sure there is everything okay. Yes, it is. So, of course, sometimes this happens when the collateralization turns over. When you open the vessel and IVUS und plane B. So we are going down here. We are already past. This is the heavily calcified plaque. I'm not sure whether I'm subintimal or it's eccentric. It looks like we are inside.
Oh, inside break.
I'm not sure actually here. Here we are.
Yeah, this is the inside break.
Yeah, but here I cannot advance. I probably need to dilate with a NC balloon. Now I'm getting forward.
Or maybe just before we do a further dilatation, you just bring a double lumen microcatheter.
So here we are. I think here we are at the crux.
Okay. Yeah. Inside.
Look,
looks perfect.
Inside. So this is the position where I will put my stents. This is safely proximal to the crux, and then later I branch out. So this is definitely luminal.
Yeah, intraluminal. Just intraplaque.
And this is eccentric plaque, I think. Yeah. Maybe it's subintimal.
That's not matter. Short segment.
This is certainly intraluminal, and this is still distal to the AV branch. So here you see the AV branch coming, at 9 o'clock. Okay. So, wrap up the session, Jacques and Dr. Wu.
Once again, I thank you mainly, Gerald, for an excellent presentation, which had all techniques and well thought choices. Excellent. I thank you for your nice presentation, and I thank all the participants for their comments. So we'll see the final result later on. Thank you so much for participating.
Thank you, Jacques. Thank you, Dr. Wu. Thank you.
Yeah, appreciate your presentation.
Was very enjoyable discussion. Very nice atmospheres. Thank you. Helps the operator.
Okay.
Great. It was our pleasure.
All right.